we have this evening with us Dr. Kelly MacArthur, who I met when she was doing some dermatology work for my own post-transplant life. And lo and behold, as we were talking, she has a passion for her work, research work she did on cancer. And of course, with Trio doing work with cancer, I said, Kelly. She graciously accepted the opportunity to come and share with our audience here, which we then will put up on YouTube and share with the national audience. So Kelly, I'm going to turn it over to you. Please feel free to take this wherever you want, but we really would like to hear about your passion for cancer research first.
Thank you so much for the introduction, and thank you so much for the invitation to come and speak here tonight. My name is Kelly MacArthur. I'm very honored to be the fellow at Penn currently in Mohs and reconstructive surgery. My path, I'm going to share a little background and then we'll go ahead and move to the slides. But my background is I actually began in medicine and have a passion for cancer research and patient care, and feel really lucky to be pursuing a path that kind of combines those two. For cancer research, I started off studying 3 different cancers: lung cancer, brain cancer, and prostate cancer, and just studied the biology of cancer as we know it, the primary tumor and what in fact happens that allows that primary tumor for cells to dislodge into the bloodstream to actually set up metastases. So did a lot of interesting research in that, took some time off of medical school to do that, and I'm absolutely delighted to be doing what I love now, which is taking care of patients and learning from the best. Dr. Miller is my mentor at Penn, along with several others, and he was really kind to give me his slides. So tonight we're going to be talking about skin cancer and organ transplant recipients.
Just before you do that, what took you to cancer? I mean, what in your life? What was it in your life? What was it that drew you into that kind of research? Because you weren't just a researcher; you were passionate about it, and you loved what you were doing. Why? What was it that brought you there?
Great question. I think that all of us are impacted by cancer to some degree. I think that if it's not ourselves, it's family members or friends. For myself, it was my father. He was diagnosed when I was very young, and he passed away when I was before I even hit teenage years. So that was kind of what drew me into it, and I already from the outset knew that I was going to be a doctor and I was going to help patients with cancer. So, but it's a great question. I think that cancer is something that impacts all of us to some degree, and I think it's a formidable enemy because it has incredible ways of just evolving and changing, and despite everything that we study to try and treat cancer in patients, it has a way of adapting and changing in just funny ways, just very interesting ways. So.
We know especially how high a risk post-transplant patients are. That's why Trio's taken on this cause. And so our website, triowebptc.org, is a learning center. And this YouTube, along with others, will be posted there. And so we really appreciate your generous time sharing that, especially with this post-transplant audience, which is different than the general audience. So anything you can tell us that's unique to the transplant world in terms of high risk is very special for this audience.
Fantastic. I think the big takeaway, even before we get into the presentation, is knowledge is power, and being diagnosed early, knowing what to look for, being diagnosed early, seeking treatment early is really key for skin cancer in particular, but all cancers. So let's go ahead and get started. So skin cancer is the most common cancer after transplant, as we're discussing. In the general U.S. population, 1 in 5 patients will be diagnosed with a skin cancer. As compared to the transplant population, it's almost half of transplant patients will get a skin cancer, 44% in a 2000 study. There are several different factors that contribute to this increased skin cancer epidemic in organ transplant recipients. In the past, infections, cardiovascular disorders have been attributed as main causes of death in transplant patients, but skin cancer is really taking it's on the rise and kind of one of the most common causes in recent literature. The take-home message as we're talking about today is 2 that I want you to take away from this presentation. You have the ability to decrease your risk with sun protection, and you have the ability to detect skin cancers before they're dangerous with self-skin exams. So this is kind of a framework of what we're going to talk about this evening. Just knowing the risk factors for skin cancers, knowing how to detect skin cancers, knowing how to prevent, and then knowing the importance of regular skin checks and early treatment intervention. So know your risk for skin cancer. There are many literature resources out there that talk about common risk factors of non-melanoma skin cancers in particular in renal transplant recipients in this study. The big take-home is that the risk factors that are risk factors for the common general population to get skin cancers, including fair skin type, older age, blue light eyes, history of skin cancer, are those same risk factors in transplant patients. Main environmental risk factor is, I'm sure we're all very well aware, is UV exposure. So this study essentially had said that history of sunburns is a main risk factor in patients. Chronic sun exposure. Skin cancers are more common in people with exposure from outdoor jobs or recreation activities. It's not uncommon that we see this in our clinic. And as you can see, and we're going to get to this later, but despite our best efforts to use sunscreen, clothing is really the best option. You can see here that this gentleman, where he's sun protected with clothing, he doesn't have nearly the amount of photo damage as he has on his the backs of his hands. History of chronic sun exposure and actinic keratosis. This is a transplant patient with actinic keratosis. They found that they're at 50 times increased risk for skin cancer as compared to those without. Transplant patients have even more risk factors than the general population, and those include the type of the transplant. We know that heart transplant patients are at increased risk, probably due to their type of immunosuppression that they're on. Presence of many of these verrucokeratotic lesions. They're just these warty, thick, stuck-on lesions, and we have pictures of those to share. Prior history of skin cancers, and again, the type of immunosuppressant. So it's the type of medication, the dose of the medication, and then how long you're on that medication. Type of transplant, as I said, we know that heart transplant patients are at kind of relative higher risk than liver, for instance. Older age at the time of transplant predicts quicker onset of the first and subsequent skin cancers. These verrucokeratotic lesions, they're essentially these warty lesions on the skin. I have a picture that's to follow that is just the common wart. So it's a little bit different than the common wart. You see on the forehead, and I think you can appreciate a little bit better on the back of the hand, that it has a little bit more substance. They're a little more rough and scaly. They kind of feel like a precancer. It's where a precancer meets a wart, as compared to the common warts. So a transplant patient with common warts, those common warts don't have an increased risk of developing into skin cancer. It is a mark of kind of the immunosuppression, but these warts here don't have that same substance. They don't have that same precancer texture of that thick scaling as just this looks like just common warts that are found in the general population as well. These are related to human papillomavirus, these warts are, whereas the verrucokeratotic, the literature is kind of a little bit divided. You'll find sources that say that it could be or it could not be related to HPV. As I mentioned before, history of skin cancer strongly predicts another one, so it's certainly high risk for, so if you get one, our concern is that you're gonna get more with time. There's 49 times increased risk for skin cancer over 3 years in organ transplant recipients with versus without a history of skin cancer, so much higher risk. Immunosuppression, as I mentioned, there are a whole bunch of different factors that go into it. So not just the dose, but also how long a patient's been on the immunosuppression and the type of immunosuppression, the kind of the regimen that they're on. The skin cancer risk parallels the extent and the duration of immunosuppression, as we're discussing. So they found that 3 drugs, so a steroid, cyclosporin, sorry for the abbreviation, cyclosporin, and Muran, have 3 times higher risk of skin cancer versus a 2-drug combination. Low-dose cyclosporin causes less skin cancer than the standard dose. and multiple rejections requiring increased immunosuppression increases the skin cancer risk. As dermatologists, we don't have the capacity to say what the transplant recipient immunosuppression regimen should be. It's certainly something that we work with, like in a collaborative manner with the transplant team. But it's just important more to know that there is that higher risk so that patients can take the appropriate measures to protect themselves from the sun and to seek dermatology for regular skin checks. And as I've mentioned before, liver transplant patients have less skin cancer risk. Again, it's related to the immunosuppression. Minimizing immunosuppression decreases skin cancer risk. This is just studies that have corroborated these findings that I'm discussing.
Kelly, can I interrupt you just a second?
Of course.
Could you talk a little bit about how our immune system and cancer work together? Since the immune suppression drugs seem to be so critical in the post-transplant life, how does the normal immune system versus our compromised immune system interact with cancer?
That's a fantastic question. So it's all a delicate balance. So when a patient is going to get a transplant, those immunosuppressive drugs, as we all are well aware, are life-saving because the ultimate goal is you don't want rejection. So suppressing the immune system, there's a delicate balance between Th1 and Th2, and I'm not going to get into the specifics of that because at the risk of becoming very boring quickly. But there's a delicate balance, and the immune system, the immunosurveillance of kind of the just things that are foreign in the body, the immunosuppressant drugs kind of decrease that immunosurveillance, and as a result, that immune system is not able to pick up things like skin cancer that are cropping up. So it's not uncommon that a patient might come in and say, I have this pink scaly lesion that keeps coming up. It seems to be thicker and more prominent in the summertime, and in the wintertime it just kind of lies dormant. And that's really your immune system is keeping those precancers in check. When you have the immunosuppressant on board, it literally suppresses the immune surveillance within your body to actually detect things that the immune system is usually keeping in check. So cancer is one of them. So it is that delicate balance. If you are going to suppress the immune system to prevent rejection, you are increasing your risk of not allowing your immune system to keep potential cancer at risk. Our cells are rapidly dividing, rapidly changing. Our immune system does a lot of things behind the scenes to keep things in status quo and homeostasis. So once you shift that balance, things crop up. Does that make sense?
Yep.
So again, just empowerment. By learning what the skin cancers look like, performing self-exams, and then seeking dermatology care, we can really detect and treat early. Transplant patients are at highest risk of squamous cell cancers, 65-fold increase as compared to basal cell, which is 10-fold, and melanoma 2 to 3-fold. Again, 65 times increased risk. So the precursor to squamous cell that we typically talk about, and not all squamous cells begin as a precancer, but the precursor are these actinic keratoses. You'll note that they're pink, they're scaly. They're the type of spot on your skin that you can't easily scrape off. So things like seborrheic keratoses it has a different type of substance, a different type of scale that you can easily pick it off, doesn't bleed, and it just goes away. We're not particularly bothered by things that go away, but these precancers are ones that the scale doesn't easily come off. They're pink. I mean, you can see this gentleman's forehead is really pink spots throughout his skin, and they typically come in crops. It's usually kind of a field cancerization is what it's called. So you can tell that he's had enough photo damage throughout his whole forehead that he has several precancers all over his forehead. And then again, you usually can feel these before you can see them. So pink, rough, scaly, think precancer, think squamous cell cancer. This is the back of the hand, and this is what I was saying before, that sometimes these could be the spots that this person might have seen this pink spot kind of on the left side there that maybe comes and goes. Maybe it gets more irritated at times, but it becomes less pink at times. That scale typically stays, and again, it's not something that you can easily pick off. And where there is one, there are usually multiple. Squamous cell cancers, so it's kind of on this spectrum that those become more, it's a thicker scale. It's not easily to pick off. You're not able to pick it off too easily. And there's just more substance. You can actually pick it right off the skin and feel that it's a little bit more adherent to the underlying skin. Advanced squamous cell cancers can ulcerate, they can bleed, they can spread. They're not as aggressive as melanomas, is what we think about and is what the textbook will tell you, I should say. But they certainly can be extremely aggressive and just as aggressive as melanoma. When they ulcerate, bleed, they can track down nerves and they can become recurrent. So this is a patient that had one on her forehead. It came back and it became inoperable because it tracked down nerves and it can invade to bone as well. They're typically locally destructive in the same way that basal cells can be, not as common, but can be. Approximately 2 to 6% can metastasize of squamous cell cancers, including this patient. And again, as I said, they can track along nerves, and they can be pretty aggressive and dangerous in certain patients. Again, ulcerate, and they can, so we talk about things like in-transit mets and satellite metastases, and it's essentially as it tracks along the lymphatics and kind of tries to get to the lymph nodes themselves. Be aware of lesions with increased risk for metastasizing. So these are the risk factors that we think about. Recurrent cancers, larger size, rapid growth, pain, tenderness, and then certain key locations, ears, lips, and genitals have been found to be higher risk of metastatic spread for squamous cell cancers. So these are that those, we're just breaking them down now. Recurrent, it was a case of a recurrent squamous cell cancer on the tip of this woman's nose. It became quite destructive quite quickly. I apologize for the graphic pictures. Larger tumors, another risk factor, a squame on the front of this patient's shin. This was the size after Dr. Miller actually excised it with clear margins, the size after Mohs was performed. Rapid growth. This was over the, does anyone want to guess how long this took to go from here to here?
A month.
Good guess. About 2 weeks.
2 weeks.
2 weeks. And again, this is, it happens. I don't want to scare you all in patients that it's common, but it certainly happens. And being a transplant patient, you're just at that increased risk. So anything that grows quickly, see a dermatologist. And neurologic symptoms. So squamous cells can, because...
Let me interrupt you just one more
Of course.
time, if I may. In your program, if a patient calls for an appointment, because you've got such an active program, typically it takes a long time to get to see you. If somebody's got this condition and it's moving quickly, how can they get that extra attention to come in right away? Do you have provision for that?
Very good question. That's why I adore my program. I think that the dermatology wait time has become really a national issue, but it really, Dr. Miller, the surgeons there are absolutely phenomenal about triaging. Once you're in the system and you're, especially transplant, like higher risk patients, transplant patients in particular, if a transplant patient were to call and say, hey, I have something on my ear that's growing, Dr. Miller, one of Dr. Sabanko, Dr. Shin, Dr. Etzkorn, Dr. Howe, they would be aware of that message, and the triage system that they have set up is such that those patients are seen soon. It is not the same type of wait time that, say, a basal cell on, like a new basal cell on a young, healthy, immunocompetent patient, like a small basal cell on like a low-risk location.
So I interpret that to mean that the patient better advocate for themselves and not just accept the fact that, well, they'll see in 3 months. They've got to argue, no, wait a minute, this is different, right?
Absolutely. And typically, I mean, once they're in the system, I've seen it that patients, when they're calling in, you're absolutely right. Patients absolutely need to advocate for themselves. Fortunately, in our system, the surgeons really take it upon themselves to really push push for patients to become their advocates. So I've not seen a situation where a patient has felt, oh goodness, like this is growing quickly and I can't see them soon enough. Understanding that, though, I know that some of our audience is not in Philadelphia, so absolutely, if you're a transplant patient, if you have a suppressed immune system, if you're seen for the first time by a dermatologist, it's really imperative that they know your history, that they know what medications you're on. I know that it's really difficult to keep track of all of that, but it's really, really important to advocate for yourself and to come with all of the information about your history. So squamous cells that can present, as I mentioned before, they can, about 40% of squamous cells with perineural invasion. Perineural invasion essentially just means that it tracks along the nerves. It makes it a lot more aggressive, and it usually translates to a larger surgical defect, like larger surgical hole. High-risk locations, as I said, lip, ear, and then genital area. Basal cells, we're switching gears here, 10-fold increased risk in transplant patients. They are more common in organ transplant recipients, but maybe not more aggressive as compared to squamous cells. So we're just going to quickly go through the different types of basal cells. A basal cell is a very interesting tumor in that it can have several different types of presentations, and it typically correlates with what we see under the microscope, which is really fascinating. This is the nodular type. It just grows like a ball. It's a nodule. It just has this ball-like feature underneath the microscope. You'll notice rolled borders and central ulcer sometimes. Again, nodular type. It has these, what we call telangiectasias. They're these like little red vessels that kind of run along the basal cell. Just something about cancers in general, they increase the vascularity in order to allow them to survive. So a basal cell relies on all of those vessels in order to keep growing. Superficial type of basal cell is more flat than the nodular type. It's more of like a pink flat lesion. It has these thin rolled borders at times. More subtle. Can be shiny, can have a crust, and then again, can be more easily felt than seen. And the superficial essentially means, this is infiltrative, I'm sorry. The last one, the superficial essentially just means that it grows on the surface of the skin. Infiltrative has that shiny appearance, and it can have a crust. And then something that Dr. Miller, I think I have another slide coming up, but this is something that he often does, and with patients with basal cells. If you actually stretch out the skin, you can appreciate this like almost like a white texture to it. It just pops right out at you. On the right, I guess on our left side, you can't really appreciate it as much, but once you stretch out that skin, you can see it clear as day. Something easy to do at home too. Pigmented type of basal cell actually looks more brown than pink sometimes, like this. So it can be a little unsettling to patients. They might think it looks like a melanoma, but this is just a pigmented basal cell. Sorry again for the graphic photos. The point of these photographs is that basal cells aren't typically as aggressive, but if you don't take care of them, they can grow and become really destructive. So patients will, there are some patients who might come in and say, well, it's a basal cell, it's not aggressive, do I really need treatment? You do if you want to live a long and happy life. They grow very, very slowly, so it's reasonable to monitor at times, but why not just take care of it before it becomes a problem? Melanoma, 2 to 3-fold increased risk in transplant patients. And we all know the A, B, C, D, E's. We're going to go ahead and go through a few of them. Really what we do as dermatologists, and really what we want to educate the public to do, is to look for the ugly duckling. So you want to do skin checks, you want to look for things that are growing, changing, look for things that are new, and look for things that stand out. So you could probably see what might stand out. That spot closer to the neck. You can advance. And then again, ugly duckling here would be this middle spot. But you could identify several of them and pick out the ones that it would be reasonable to biopsy all 3 of these. Some melanomas don't actually have pigment, and they present more as little pink lesions on the skin, and they're just different types. This one's a desmoplastic melanoma. Amelanotic melanomas in literature is essentially just a melanoma that doesn't produce pigment, so it doesn't look brown. And something important to know is that for patients who have a lot of moles, it's really hard to find an ugly duckling because they're covered in moles. So in those cases, it's even more important to see a dermatologist, and some dermatologists will even just sample the most atypical looking ones to serve as kind of just a background check of kind of what type of pigmented lesions does this patient make. Evolving lesions, as I said, anything changes, you'll want to let your dermatologist know. What do you think the percentage of melanomas present with a change in size, color, or elevation? About 3/4. We not uncommonly hear this mole popped up a couple of months ago. Interestingly, only about 1/4 of melanomas arise within a pre-existing mole. So vast majority of them come up out of the blue. We hear this too, my mole is getting bigger, so changes in size and color are noted in at least 70% of early melanomas. Bleeding, pain, itching, and elevation are often signs of more advanced melanomas. This is not to scare you if you have an itch, but just know what to look for. And melanomas can be flat. Look everywhere. Really important that that yourself and your dermatologist are looking everywhere, including between the toes. This actually ended up being an 8-millimeter melanoma between the second and third toes. And because these are areas that patients and providers don't often routinely look, melanomas on the hands and the feet are often detected in more advanced stages. Organ transplant recipients are also at increased risk for tumors of kind of the hair follicles and sebaceous glands. We call them appendigeal tumors. It's just more of an FYI. And how do you protect immunosuppressed patients? So the most important thing that we keep drilling home is the need for sun protection. That this whole immunosuppressive dosing, that's in accordance with the transplant team, and dermatology is not in control of that by any means. But you want to treat precancerous skin cancers promptly, aggressively, and consolidate those efforts for screening and surveillance. And helping yourself is protecting yourself from the sun, doing skin checks, just knowing what to look for, and seeking treatment early. Protecting yourself from the sun is the only behavior that can prevent skin cancer. Something, too, that I just want to put in a plug here is it's not uncommon that I've heard from patients, you know, I protect myself from the sun, I never go out in the sun, I've gotten skin cancers, now I hardly see the sun, why am I continuing to get skin cancers? That's from sun that you got years ago. Please know that the more you're protecting yourself from the sun now, you are preventing even more skin cancers in the future. Knowledge about skin cancer and compliance with sun protection are low among the organ transplant recipients. According to this 2005 study, only 6 out of 10 kidney transplant recipients consider themselves at high risk for skin cancer, and 6 out of 10 of those transplant recipients didn't apply sun protection to their skin. We want to change that. Regular sunscreen use can help prevent the AKs, actinic keratoses, precancers, and squamous cell cancers in organ transplant recipients. This is just a 2009 study. Multiple studies have shown that none of us do an adequate job of applying sunscreen. Again, the importance of sun protective clothing. Sunscreen has a lot of drawbacks, as we all know, that the greasy feel, the white color, the high cost of them. And as I keep mentioning, clothing is far more effective. You can see this gentleman's been wearing a hat for most of his life. Unfortunately, that hat didn't have a brim, so you can see that he not only got quite a bit of sun damage on the back of his neck, but also a squamous cell cancer on his right ear. And it was an aggressive one. Again, sun protective clothing is important. You want to look for UPF. Specialty dermatology clinics can reinforce that compliance, so it's important to have regular skin checks with your dermatologist and present if anything changes. What percentage of melanomas are detected by patients or their partners, do you think?
50.
Greater than 75%. 88% of melanomas are detected by patients. It's pretty compelling. So only 1 in 4 are at high risk for melanoma have performed a whole body skin self-exam in the last 12 months, which is, this was a 2004 study, so I'm hoping that 2018 things have changed. Regular surveillance helps detect skin cancers at early stages, therefore reducing the morbidity and mortality. Dermatology Clinic for Organ Transplant Recipients offers a comprehensive dermatologic care for organ transplant recipients, well, with a focus on skin cancers. I'm really lucky to be training in an institution where transplant patients are seen with the most surgeons and kept under close eye, so early and effective treatment is really the mainstay, but again, understanding that not all of our viewers are in Philadelphia, it's just really important that you're seeing a dermatologist who feels comfortable treating high-risk patients. Again, early detection and prompt treatment improves outcomes. And as I mentioned before, you want to treat skin cancers in organ transplant recipients. In order to treat it, not only requires multidisciplinary care, but it also requires different modalities. So for early lesions, we tend to think about scraping and topical treatments like 5-fluorouracil. For more invasive lesions, that's where most surgery is really indicated for certain tumors, certain locations, or excision. So I hope that we touched on all of these objectives. Just knowing the risk factors, being able to know how to detect skin cancers, preventing skin cancers, and just knowing the importance of regular skin checks and early treatment. How can we reduce the morbidity and mortality of skin cancers? It's just clear communication among caretakers, and really having good, strong relationships with your dermatologist is key. If you can see a specialist, do it. I think that's a good take-home point. And as I said before, I'm extremely lucky to be training at such an incredible institution. Dr. Miller is my mentor, and then these 4, Dr. Sabenko, Dr. Shin, Dr. Etzkorn, and Dr. Howe, have been absolutely phenomenal mentors to me. It's been really such a privilege to be trained by them. Thank you so much for inviting me to speak, and I'd love to take any questions.
I've got a bunch of them here, but let me ask others first. Who wants the mic?
Question I have, it relates to the amount of immunosuppressants that one is on. You indicated that sort of the lower doses, the less risk you have.
Mm-hmm.
And how do you know that you're at less risk? I mean, can you give me an idea of what that might look like?
That's a great question. It's all relative. So they've done studies that show that patients on a certain, I'm going to refrain from using like numbers, but patients that are on a higher dose, when they get lots of skin cancers, and then the dermatologist kind of talks with the transplant team, and again, it's such a delicate balance, because that organ is far more important than skin cancers. So having that delicate balance and having that conversation between the dermatologist and the transplant team, they might come to a consensus of decreasing the immunosuppressant if the transplant team feels comfortable with the organ not having risk for rejection. I honestly wouldn't even know the first thing about the dosages. Like, we don't deal with kind of the dosages and titrating the dosages by any means. And we don't even usually recommend that changes are made. It's just more important to know that if you're on 2 immunosuppressants versus 1 immunosuppressant, you're at a higher risk. It's all relative. If you're on 3 versus 1, you're at a higher risk. If you've been on it 10 years versus 5 years, you're at a higher risk. So knowing those risk factors, again, not trying to scare patients, but just understanding that it's even more important to see a dermatologist and to protect yourself from the sun.
Thank you.
Of course.
Pam, anything?
No, I'm good.
Sue? Bob? No.
I just have a question. I'm not a transplant patient, I'm a living organ donor, but I do take Imuran for a problem that I possibly have. Does that put me at a higher risk for skin cancer also?
That's a fantastic question. It does. So the risk for skin cancer related to organ transplant recipients is due to the immunosuppressing drugs. It doesn't have to do with the organ or the surgery. It's actually the immunosuppressing drugs. So Imuran is one of those that are used. It's an immunosuppressing drug used in organ transplant patients and used for lots of other conditions. So yes, it would. Again, maybe the dosage is not such that it would put you at significantly increased risk, but it's important to know that it would. Other medications out there like prednisone, some patients are on prednisone for, gosh, prednisone treats so many different things, and some patients are on it for chronic periods, including for things like rheumatoid arthritis, and that definitely puts them at increased risk. So this talk is not just specific to organ transplant patients. It's really specific to, it really pertains to anyone on immunosuppressing medications.
Okay, another question I have is I had a melanoma here that was surgically, plastic surgeon removed it.
Mm-hmm.
And is that more likely to come back in this spot?
Good
I
question.
apparently got it all.
Good question. So I'm sure it not. If they feel that they got it all, then absolutely. I'm sure you were in great hands. Something that I did take out of this talk at the risk of it being too long is just the difference between Mohs surgery, which is what all of these providers do, and excisions. Just the really quick explanation of it is that with excisions, the tissue, when it's removed, it's processed like a bread, so it's like sliced like bread slices. And then what is given to the pathologist to read underneath the microscope, they read a very, very, very small margin of that sliced bread. Because as you can imagine, when you slice bread, if it's raisin bread, for instance, you're slicing it, is there a raisin on the edge or not? It's completely, it's arbitrary, really. So with the Mohs surgery, what is done is it's more of kind of the analogy is used as like pie crust, and the edges are laid down so that you can actually see 100% of the margin. So that's why in particular locations, particular cancers, we recommend Mohs surgery, but understanding that in some areas of this country that Mohs is not available to all patients, and certainly our providers in plastic surgery do a fantastic job as well. So,
Yeah, I had a basal cell here that was removed by one of the fellows at Penn, and you can't even see the
Great.
scar that was left from it.
fantastic.
Thank you.
Of course. Thank you.
Just to add that, I know we sound like we're promoting your program. We certainly are, because we're all fans. But it is amazing to me, and certainly with the graphic pictures you've shown, we've seen that ourselves in the work you've done on us. And it is amazing that your practice is so painless. And I want to say that because people listening to this got to look at this and say, oh my God. Yeah, it looks terrible, but believe me, I've had it all, no pain whatsoever during the surgery. Hey, later on it may wear off, you get some pain later on, but it's painless surgery. And the other thing that really is amazing to me is how extensive some of these Mohs surgeries are, and yet when you're recovered, as Sue was just talking about, you don't even see them. I mean, yeah, you look close to the mirror, you can find them, but somebody would have to be looking for them. And so, is it typical, or is it just your program, and Chris in primary, that you don't need to do the plastic surgery later? The work he does is so clean, or is it normal to have Mohs surgery done and then be referred to a plastic surgeon?
Very, very good question. Again, I feel extremely privileged to be training in a program with incredible, they're Mohs surgeons, they're also incredible reconstructive surgeons. So no, they are phenomenal at what they do. So I would send my own family members to them to get plastic surgery, because they are really, all of them are just such perfectionists and so phenomenal at what they do. We all work very well with plastic surgeons. Most surgeons have a very good relationship with plastic surgeons. So there are definitely differences in institutions. Some might work more like with coordinated closures is kind of what we call it. So if the Mohs surgeon in your area doesn't close the defect, that's not a problem. So it does happen, but this particular team is just phenomenal. They're really amazing.
As I said, I was telling you when I was in the chair and you were sawing me up, and literally, I've got a triangular shaped thing. I measured it today. It's 2 inches on each side of an equilateral triangle. Okay? And Kelly spent over an hour putting in over 100 stitches in that triangle. And we're now at the point of recovery where you'd never know it. You'll see it because the skin is so different. But I gotta say, it's amazing what you do. And just to add to that, one of the first things that Chris did on me was in the forehead. There was a little something up there, and he went to work on it, and he said to me, "You're gonna have more stitches than you would have expected." Well, I had no idea what to expect. But when it got through, he had an incision from my hairline down to the tip of my nose for what I thought was a minor little thing. I was in awe of it, and months later, I passed him in the hallway over at Penn Medicine, in the bridge between the hospital and the outpatient area, and we stopped and talked, and he said, he looked at me, he says, "Oh, I can fix that." And I looked at him, I said, "No, that's well within my realm of vanity." He said, "But I like doing that." I said, "No, on me you're not." And so today, if you were to look at my forehead, you'd have to come pretty close to see there was something there. But he wanted to fix even that. The other more serious thing I'd like to just talk a little bit more about, my original attitude towards skin cancers was no big deal, it's on the skin, it's on the surface. You've used the word metastasize quite frequently, and I now know what that means, but would you talk a little bit more about why it's so dangerous to have what looks like simple stuff on the skin, using that term metastasize, explain it, and what's the real danger?
Great question. So skin cancers, it's not uncommon that patients kind of think that, oh, skin cancer is not, so it's very interesting actually to just, and this kind of gets back to my research that I did in medical school. When you hear the word cancer, people have a very different interpretation. Some will say, oh my gosh, cancer, like this is bad. And others would say, well, skin cancer, just as you said, it's on the surface of the skin, it can't do anything bad. And really, it is really important to have them treated. As I mentioned before, we have several different types. Basal cell is, like, by the textbook, they say it's not that bad. It grows very slowly, very unlikely to be aggressive. But with the graphic photos that I showed you, it certainly can grow, and it can become a huge issue to morbidity of life. So it's important to treat those so that you can just go about your life just as usual. With squamous cells in particular, especially in patients who are immunosuppressed, those can track along nerves, and those can spread throughout the body to other organs. Very low likelihood of doing so, so I'm not trying to scare, but it's very possible, so it's important to treat those, and they can be very locally destructive as well. Melanomas, we treat those, they're all aggressive. We don't like those. We want to diagnose those very early, because those absolutely can spread to other organs and cause a lot of issues if they're not diagnosed, treated early.
He certainly got my attention years ago when he did a presentation similar to this, because yes, the wounds are so graphic, but I'll never forget, there was one where he showed the side of a man's face, and he had the whole side of the face exposed. looked terrible. And he explained this was somebody who didn't come in time, and the gentleman was out, I believe it was 17 years post-heart transplant. And as a novice in his audience, I had not seen him yet. I was 17 years out with a heart transplant, and I looked at this, and the next slide basically had the message, this person didn't make it. 3 months later, they were dead by not taking the early prevention you just talked about, or early detection you talked about. And so that drove me to his practice, and I've been there ever since. And so I have some other words about the prevention that I just wanted to repeat from him. He has this thing, he says, you know, if you're wearing the hat and the brim isn't big enough that people are laughing at you, it's not big enough.
Sounds like something
I
you'd
actually went
say.
out and bought a sombrero on the website, on the internet, and brought it to his office with that saying past the front of the hat, hoping he would put it up in his office on the wall so patients could see it. And so that's part of your message. I think it's one of the most important parts. And so like you said, if they're not laughing at you, you don't have big enough brim there yet. The other thing that I just wanted to say is you mentioned something that we have benefits here in the Philadelphia area, because Penn Medicine, and your program especially, offers many free events for having practiced dermatologists look at and diagnose anything they see. Better than we can even a self-exam. I don't know how common that is across the country, but my recommendation to our audience is if you see those opportunities, go take advantage of them, go take a look at them, because in my early stages, I had a couple dermatologists that I used when I lived in different places. And I would go in, nobody ever had me stripped down like Chris does, okay? Embarrassing as that was in the beginning, I've lost all vanity, so it's not a problem anymore. But they would say, so what's going on? And if you pointed something out, they would look at it and treat it. But if you didn't point it out, hey, I was happy, fat, dumb, and happy, as I said, because I wasn't having any of these things done. And then when I went to him, and he started in the hair, searching for anything, and went down to the toes, as you showed in some of your slides, I had never experienced that before. And so I would again add to what you've said to our audience. If you have a dermatologist that's just doing superficial, it's dangerous. You need somebody who's really going to embarrass you by looking that closely at things, as Chris and this whole team does.
And I would also encourage just ask for a gown when you're waiting to be roomed. We know that it's not comfortable sitting in a gown waiting for your provider to come in, but it is different. We offer everybody a gown, but absolutely for those watching who are not in Philadelphia, just ask for a gown the minute that you get in that room, and being in a gown, your provider is going to look at you.
Does anybody else have any other questions? If not, what I'd like to do is present Kelly with our gift of thanks for coming out on a weeknight after a busy day.
Thank you.
Your long trip back from, where was it, Phoenix?
Phoenix.
And so, Art, thank you. Daily inspirations.
Thank
to
you
keep
so much.
going in what you do.
Thank you
and
very
may you
much.
just each day look at this, at the end of the long day, look at it and feel, this is good. I should keep doing this, okay?
Thank you so much. I really appreciate it. It's been an honor.
Thank you very much.
Thank you. Thank you so much. Appreciate it.
Everybody?